Welcome. My name is Alan Barker. I'm Professor of Medicine in Pulmonary and Critical Care at Oregon Health and Science University in Portland, Oregon. I'm a clinician and educator. I'd like to share with you today an overview of bronchiectasis, including the diagnosis and treatment. Bronchiectasis is defined as a permanent dilatation and thickening of the airways. The airways in the lower lobes are affected greater than the upper lobes, as shown in this coronal chest CT imaging, in which one can see the dilated and thickened airways in the so-called cystic bronchiectasis. We ask, who is affected by bronchiectasis? In this graph, in which we show the rate per 100,000 in the United States versus age, we see that this is a condition of the elderly, or at least senior citizens. We also note, as is shown in magenta, that more women than men are affected. More recently, if we look at the chronic obstructive pulmonary disease population in the United States, which numbers 12 to 24 million, it's been shown that somewhere on the order of 20 to 42% may have bronchiectasis, expanding the affected population to several million patients throughout this country. The pathogenesis of bronchiectasis leads directly to our management. I've shown an example of a genetic defect that affects ciliary. That includes the so-called Carjaginers or ciliary dismodal syndrome. We can see the dextrocardia and the situs inversus in this chest x-ray. But all causes of bronchiectasis affect cilia that become less effective or dismodal, slowing transport of mucus, leading to the thick airways, mucus plugging, and tissue damage that includes the so-called vicious cycle in which we have recurrent inflammation, infection, inflammation, infection, and our therapy directly affects or tries to improve or reduce the inflammation with the use of anti-inflammatory agents, reducing infection with antibiotics, and enhance secretion removal with the so-called bronchial hygiene or ACT, Airway Clearance Therapies, to help us eliminate or reduce this vicious cycle. Bacteria in this disease are critically important. The bacteria are slightly different than in asthma or COPD, and they include Pseudomonas aeruginosa. The importance of sputum culture to identify this virulent organism is key. The presence of Pseudomonas aeruginosa is associated with a variety of poorer clinical outcomes, not just airway inflammation that's increased. There are more frequent exacerbations, mortality is worsened, lung function is worse, there is increased risk of numbers and duration of hospitalization, and quality of life is clearly worse in those bronchiectasis patients that have Pseudomonas aeruginosa in their sputum. Management is key. The foundations of such therapy include treating acute infectious setbacks or exacerbations, suppressing or reducing the microbial load, particularly of Pseudomonas aeruginosa, reducing inflammatory responses, and as we will discuss subsequently, promoting bronchial hygiene or airway clearance, and attempting treating underlying conditions that may be identified. We have a variety of techniques that are effective and important in airway clearance or bronchial hygiene. In every chronic disease, maintenance or rehabilitating our fitness is key. That may include walking or other forms of personal training directed exercising. We also concentrate on strengthening the respiratory muscles, which are so important not just for general respiratory muscle strength, but to enhance coughing. We may use other techniques such as the so-called directed or huffy coughing. We may incorporate postural drainage and physical therapy. Other techniques are also effective, including the active cycle of breathing, autogenic drainage, the assistance of positive expiratory pressure devices to loosen mucus, and more recently, the high-frequency chest wall oscillatory or vest therapies have become important and efficacious. There are two types of the high-frequency chest wall oscillatory devices, or vest therapies. First is the air bladder, in which a vest is applied to the chest, must be attached to a generator connected to an electric outlet, so a person has to be either in bed or in their chair. Embedded in the vest are air bladders that are inflated with air and squeeze the chest wall or the torso, and subsequently the airways in the lung to loosen mucus to assist clearance. This is generated by the air bladder in which oscillations are applied. It may be uncomfortable for some patients because of the pressure by the air bladders that inflate and deflate, and the person is immobile during the application of the air bladder technique. More recently has been the development of the mechanical oscillatory technique. Again, a vest is applied, but inside the vest is a battery, so the patient can be mobile. There are motors embedded inside the chest that create direct mechanical forces to oscillate the chest wall, as opposed to using the pressure created by the air in the bladders. This approach mimics so-called manual chest physical therapy, our traditional technique, and actually does not squeeze the chest, so inspiration is not limited. The user can be more mobile, and the device is not tethered to an electrical power source. All chest physical therapy is subjected or have been subjected to scientific scrutiny and has been summarized in several Cochrane reviews over the past 17 years. In cystic fibrosis, there has been found equal efficacy and acceptance, as reported several years ago. And bronchiectasis has also been studied, or the airway clearance has been studied in bronchiectasis. Conclusions include no difference between traditional chest physical therapy and the other techniques in terms of pulmonary function measured afterwards. During acute exacerbations, all techniques improve outcomes, and a number of studies have recently reported patient preferences for the self-administered techniques, including the high-frequency chest wall oscillatory techniques. A couple of requirements are required by insurance carriers, including Medicare, when prescribing the vest or high-frequency chest wall airway clearance techniques. First, the diagnosis must be confirmed by chest CT. Daily productive coughing for the 6 months prior to the order must be documented in the clinical chart, or there is documentation of exacerbations up to 3 within the prior year prior to the order, and there must be documentation by chest chart notes that other treatments such as the flutter valve, percussion, postural drainage have failed to adequately mobilize secretions. In summary, there are several takeaway messages that I'd like to summarize. Bronchiectasis is often missed or underdiagnosed, and there are literally hundreds of thousands, if not millions, of such patients in the United States with bronchiectasis. While there are no approved medications for bronchiectasis, there are effective airway clearance therapies with demonstrated efficacies. They include high-frequency chest wall oscillation, that is an airway clearance treatment that is effective, well-tolerated, allows self-administration, and is preferred by many patients. Thank you for your time today. I hope this presentation was helpful and enhanced your understanding of bronchiectasis.